Hello, everyone. My name is Brett Mauser, managing editor at St. George's University, and today we are joined by Dr. Justin Roberts, chief anesthesiology resident at Robert Wood Johnson Medical School in New Jersey. Dr.
Yes.
Roberts, thank you for joining us.
Thanks for having me.
Dr. Roberts is on the front lines as the COVID pandemic is going on. We're going to check in with him and see how things are going. So, Dr. Roberts, how would you describe what you and your hospital have been through over the past few days and weeks?
So the past few days and weeks, I guess, have brought a lot of, I guess the best way to describe it is change. The only thing that has been consistent about this whole thing has been, change in the way that where we're providing care for these patients, providing new locations for intensive care units, trying to delineate, what units are going to be COVID units, what units are going to be, exempt from those COVID patients and kind of protect their own, comorbidities that are existing and not add to them. So from like a system standpoint, that's kind of what we're dealing with. We've made a lot of changes during this time, and like I said, for the locations of the patients, but also kind of the role within we're trying to treat these people. So there's a lot of stress going on in the hospital. A lot of people are experiencing a lot of those stressors both at home and the fear of the unknown. So everybody's really trying to work together during this time. One of the nice things to see is different, lines of care, cardiology, interventional radiology, anesthesiology, all these different lines kind of coming together and really trying to help people.
Is it a situation, you'd mentioned it before, but is it a situation where coronavirus patients are making up most or all of the caseload in the hospital, or is there a lot of business as usual going on?
So in terms of business as usual, so from an anesthesiology perspective, we staff many locations during the day. So we staff our general OR, and then we also are staffing places like cath lab, endoscopy, interventional radiology, things like that. So there's a lot of different locations that we do staff. We're definitely trying to, from a state mandate, there's all non-essential procedures are being canceled. So we're definitely looking at those cases on a day-by-day basis, and administration is kind of deciding, what cases need to go, what cases should wait until it's a safer time for the patient. So at this time, we're really trying to be very patient-centric. So business as usual is definitely not the case. We're not doing a lot of cases that are quote-unquote the elective cases. We're not doing those right now. There's been a complete halt to those, and only the cases that need to go, whether it be, time-sensitive surgery for anybody with, large tumor burden, cancer procedures, or any sort of traumas that come through the door, only those urgent cases are going to the OR. So business as usual is definitely not the case, like I said. In terms of the patient population that we're treating, we're definitely, those patients who have COVID also are going to need surgery. So one of the things that we're doing is, trying to implement plans and make sure that these patients who do have COVID are going for procedures and, going to and through them safely. And that's not only the patient, but making sure that all the support staff, from nursing to the surgeons to the anesthesiologists, making sure that everybody is doing this safely, is vital.
It's been pegged as a virus that has largely affected older patients. Have you found that to be the case, or are there some other patients who are coming in that you've seen?
Oh no, there's patients for all age ranges. We're definitely seeing kind of a smattering be across all age ranges. Of course, you do always, you hear, okay, if, you're elderly or if you have multiple comorbidities, that you're more prone to, getting the disease. I think we look at the process like, if you get the disease, if you get, the COVID virus, how that's going to affect you. We see people who are just, getting a small, mild fever and then cough, and then that's kind of it. And then you talk to people who get it and they say, I felt horrible for, 7 days, all the way up to, the patient who comes in severe respiratory distress, goes into, acute respiratory failure, and then requires, intervention, requires intubation, to put on mechanical ventilation, all through the different kind of modalities that we're using to treat these people. So they're having comorbidities is not going to, say, okay, you're going to get this disease, but it definitely doesn't help. We always read about, diabetes, hypertension, any sort of existing respiratory diseases that you have. So these comorbidities don't necessarily help you, but it's not necessarily saying if you get this, that it's going to affect you like this. A lot of the information that we're getting is always new, so as we go through this, everybody's kind of going through this together. We're always getting new information on medications to use, how the disease process is evolving. So all this is an ongoing process. But to say that one patient population is being affected more than the other, I think it's really institutional dependent. And I think we're really going to have to wait for all of that data to come in later.
Dr. Roberts, we're well into the practice of social distancing. Schools and businesses are closed, and a number of people are working from home. Can you see an alteration in the trajectory of this virus as a result of those efforts?
Definitely. I mean, social distancing we're already seeing is working. Just based off of how the virus is spread. It's droplet. It spreads. So just to make sure that you're maintaining your distance from people. I go grocery shopping for our family, and, I love to see that people are spaced out in 6 feet increments, because, I definitely don't want, I see the bad that goes on with this. I see these people going into respiratory failure, and, you see, unfortunately, at the hospital, we're doing a lot of good, but, bad things occur. And it makes me happy to see these people social distancing, and really protecting themselves, wearing masks over their face, and maintaining that 6 feet. So I know that there's people saying that the numbers are flat, and I love to hear that, because I don't like to see, these things affecting good people.
And we are in a different spot than you are, in that we're doing our job working from home, but you are doing your job in a hospital. So it is affecting, the doctors and nurses and hospital staff there. Can you explain that a little bit, how it's the challenges that are facing you and your colleagues?
It's a very stressful time. I think the thing that worries a lot of people, I should say, is, the fear of the unknown. We're always seeing these people come down with the virus, and and trying to help people, and we're doing our best to protect ourselves with our PPE, face shields at our hospital. Whenever I go in to intubate somebody, we have a dedicated airway team, and we're doing it wearing these things called PAPRs. They essentially just look like helmets that are forced purified air that goes through a face shield. So we're both wearing that, including surgical gowns and things to cover our legs. So our hospital does a great job providing us with this PPE, but still, if you come out with a little bit on your arm and you don't wash your hands the right way. So there's a lot of, unknown. And I think that provides a lot of worry, for people within our department. I think we're doing a very good job reappropriating staff, putting people in roles that they feel comfortable in, and also providing algorithms and checklists to make sure that they're doing everything that they need to, and they can provide themselves the best sort of protection. So it helps bring that stress level down a little bit.
You'd mentioned a change in roles for a number of people. Does that apply to you? Do you feel that what are some of the responsibilities that you have as an anesthesiologist, and do you feel as though you're taking on tasks that you aren't accustomed to doing?
Anesthesiology is very unique in that, you know, our day is always, even before this, the day was highly varied. You know, 1 minute I would be on the peds floor doing, you know, a lap chole. The next minute I'd be on OB placing an epidural. The next minute I could be, you know, in the cardiac room doing a quadruple bypass. So our days are very highly varied at baseline. So for this, during this pandemic, you know, one of the things that we're kind of being, taking a leading role would be, you know, in intubating these patients. But that's something that, you know, in anesthesiology, we're essentially, you know, the airway experts and access experts. So, you know, we're able to secure these airways safely, effectively, and to reduce the risk to everybody else around us and to keep that patient safe. So not being thrust into roles that we're not accustomed to. The only difference is that, you know, now we're wearing a lot of personal protective equipment and washing our hands a ton more. So I really don't think it's anything that we're not accustomed to. It's just an added level of, I guess, stress.
You know, it's not a one-person job. You've stated that in our discussion. And as a chief resident, you have a team of residents kind of under your purview, and then you're working alongside nurses and hospital staff. How would you describe the camaraderie that's developed during what is surely a very challenging time? As
one of the chief residents, I'm extremely proud of our residents during this time. We have a great group of residents, hardworking, dedicated, and they definitely have stepped up during this time period. You know, we have to, you know, one of the things that the hospital needs to do is to find, you know, we're modifying ICUs. We've already flexed up to staff one of those ICUs. So we've provided some of the residents, we provided, I think, I want to say about 6 or 7 residents just to dedicated to staff that ICU. And these are COVID patients involved in intubations, positioning of these patients after they've been intubated, proning them, which is placing them on their stomach to improve sort of their pulmonary physiology, and optimize these patients to ultimately lead them to get better. So ICU management, we have a dedicated airway team. We have an anesthesia vent team, which we've deployed our ventilators that we use in the OR onto the floor. So we have a dedicated team that is rounding on those patients and ensuring that those ventilators are optimized and functioning well for those people. We also have a line team that we've deployed within the hospital, and a consult team, because these patients are going to are in other areas of the hospital, and you know, if different sort of providers have you know, questions, that we can, you know, basically come together and have you know, an informed discussion what might be the best course of action for this patient, you know, with ICU, with residents, with anesthesiology attendings, just to kind of have a meeting of the minds and get an optimal outcome for that patient.
Dr. Roberts, I think we all hope that this is a once-in-a-lifetime experience. I'd imagine you feel that way in a hospital setting. How would you say that it has changed you, or how do you think it will change you as a physician going forward?
I think this will change a lot of my practice in the short term and the long term. I think that a lot of times one of the hardest things to do as a healthcare professional is to, not run towards somebody who's having, trouble, who's in extremis, a patient who needs help, so to dial that back a second takes a lot, and just kind of take a step back and say, okay, we need to do this safely and we need to do this effectively. So if that means taking a step back and optimizing a plan before we enter a situation, that's what we need to do. So I think that it's definitely going to change the way that I do things. I know I think I need more lotion. I've washed my hands so many times that, my hands are starting to crack, but, so it's going to change a lot of us in terms of, the way that we protect ourselves. I think, whether or not people are nonchalant about this beforehand, wearing a mask, wearing eye protection, I think this kind of brings some of those things back to the forefront and makes you think, are you protecting yourself the way that you should be? Because at the end of the day, we need to make sure that we're taking care of ourselves as well. I have a wife and 2 kids, and I don't want to bring anything home to them.
This has undoubtedly been, an enormous undertaking for you and everyone at the hospital and in clinical centers and hospitals in the U.S. and worldwide.
Yeah.
But has it in any way reminded you, or how has it reminded you about why you went down this path to begin with to become a physician?
I was having this conversation like 2 or 3 days ago because even in the time that, it's stressful going to the hospital. It's stressful doing these things. It's stressful going into intubate these people when they're, in extremis and desaturating and, having a very, very difficult time. But I am so excited to go to work still. I love what I do. I'm very, very lucky. Like I said, that conversation 2 days ago, we were saying that it's an amazing job. To be able to have a skill set that we've developed over the years, to be able to use that and help people, and you see these outcomes that are great. I mean, that's what we do. That's why we do what we do. And it makes me smile. It makes me happy. And of course, it's stressful, but at the end of the day, really trying to remember that we're making a difference and we're helping people.
Dr. Roberts, finally, there are, many new med school graduates who are entering residency this summer and even earlier in some cases. What words of inspiration can you offer them during this time?
There's a lot of new graduates coming out, and I know that some schools are even graduating their students early. I would say take a step back and realize and remember why you went into the profession, to help people, to take care of people and ensure their safety when they can't protect themselves. And just to make sure that, that you're centered as a person. I would also say that, make sure that you keep your support structure outside of the hospital strong, because you're going to need it. There are days when you're going to have very stressful days. You're going to see things that, are going to, get you down, or have an experience that you just need to talk about. So make sure that you have a support structure outside of the hospital that is strong and that you can access. And don't be afraid to ask for help. As a new graduate, I felt like a MS1 again. You realize just how much you don't know. The only difference is that you just have an MD or a DO after your name. So the only difference is now they call you doctor, but in reality, clinical medicine is a different animal. So please don't be afraid to ask for help. It's not a sign of weakness. It only enhances your knowledge base. And it ensures that you're doing the right thing for the patient. Don't think you know what you're doing. If you're unsure, ask. It's fine. You're still getting the best outcome for the patient, and you're doing, the right thing by them, and you're learning in the process.
Dr. Justin Roberts, Chief Anesthesiology Resident at Robert Wood Johnson Medical School in New Jersey. Thank you for your time. I hope you stay safe and stay healthy. And thank you to you and your colleagues for all the terrific work that you're doing.
No problem. We enjoy doing it.
Thank you.
Thank you.